I'm going to discuss the next 10 to 12 minutes about the stent optimization criteria with OCT. What are the current updates? The stent optimization doesn't start after the stent implantation alone. It starts much before the stent implantation. When we have strategy, we have to have a plan before the PCI starts. Then we know the morphology of the lesion. We should know the length of the stent. We should know the diameter of the stent. Then after stent implantation, we have to we do OCT and look for what are the problems incurred during the stent implant, whether there is a dissection, where the mala post, or it is an under expansion, what are the problems we are facing. So many trials, we have gone through the different studies, there is no unified criteria for stent optimization. And different research group of OCT in different trial, like doctor's trial and Illumin 3 trial, they have used different parameters for stent optimization. However, we have some expert consensus on the European Association of Percutaneous Cardiovascular Intervention. And pre-stenting imaging, the consensus are more like this. The pre-stenting imaging can improve the outcome of the stent optimization by identifying the plaque composition and distribution. If the morphology says that if there is a severe calcification, your strategy is different than a soft plaque or if it is a thrombus-containing lesion. And the choice of stent size and the lesion preparatory strategies also differ along with the morphology, according to the morphology of the lesion. And if you are using OCT for the pre-PCI, it is better to use 20 to 25 mm beyond the lesions, that is about 75 mm OCT pullback. And calcific lesions are better stratified by OCT than the IVUS. If you have a lipid-rich lesions, it can increase the embolism and it can increase the event, but however, the clinical outcome is not very clear. You can see the influence of calcium on the stent expansion by OCT. It usually follows a rule of 5, that is, if it is more than 0.5 mm thickness, and if it is 5 millimeter long calcium, and it is more than 50% of the arc is involved with the vessel, then the results, we have to really prepare the vessel very well. There is a calcium scoring is there, 0 to 4 points. You can see that, and the maximum calcium angio, that is more than 90 degree, more than 180 degree, it is 1 point, and more than 180 degree, 2 points. And maximum calcium thickness of 1 point and calcium length is of 1 point. And what the consensus is, OCT, in contrast to IVS, it can often assess calcium thickness. Total calcium mark is more than 180 degree, and increased calcium thickness is more than 0.5 millimeter, associated with a greater risk of stent under expansion. And evidence of calcium fractures in following lesion preparation is associated with the improved stent expansion. If there is a severe calcium more than 180 degree, then the absence of calcium fracture following the initial lesion preparation, you have to be more aggressive in preparing the lesion before the stent implantation. Although the stenting of lipid-rich plaques is related to an increased risk of peri-procedural MI and no reflow phenomena, the procedural consequence of lipid or necrotic pool detection by OCT prior to the PCI remains unclear. Coming to the stent sizing, how do you size the stent? Whether you go from the proximal diameter, whether you go to the distance referral diameter, whether you go to the lumen diameter, whether you go to EL to EL, there is no definite consensus on this. Stent under expansion usually leads to stent thrombosis and stent restenosis. Stent diameter selection depends on the mean reference diameter versus EL. If you take different studies, they have used different criteria. And MLA derived by OCT is usually less than the MLA derived by the IVUS. Incomplete lesion coverage is one of the predictors of stent failure. If you see here, you can see the middle of the stent, there is an under expansion and MLA side. If you see the proximal reference diameter, if you see the distal diameter by OCT, this is an aggressive approach. If you are taking the conservative approach, smallest reference lumen should be the criteria to put the stent diameter. However, if your very aggressive approach is required, then the smallest referral EEL, especially for IVUS, is taken as a criteria. You can see the OCT criteria that the smallest reference EEL is the maximum diameter compared to the smallest diameter if you are taking the smallest referral lumen. So, the stent sizing by coronary imaging, the beneficial effect of imaging guided PCI does not appear to be strictly linked to the algorithm used for stent sizing by IVUS or OCT. From a practical point of view, the distal lumen reference based sizing may represent a safe and straightforward approach, because if you use EEL, if you are oversizing, there is a chance of rupture. Though the maximum stent areas usually will give a better result than the minimum stent area. If you are using mean distal lumen diameter, you have to add 0.25. If you are using EM as the diameter, then you have to reduce 0.25. If it is a 3.76, you have to use 0.25 less sized stent. When using OCT, EM reference-based sizing strategy appears feasible, although it is more challenging, especially in a diseased segment. Appropriate selection of landing zone is crucial, as residual plaque burden is, and particularly lipid tissues at the stent edge is associated with the subsequent restenosis. Co-registration of angiography and IVUS or OCT a useful tool to determine stent length and allows for precise stent implant. Regarding the post-PCI strategy, there are important things is under-expansion, malapposition, stent edge dissection, geographic plaque miss, and thrombus. You can see the stent apposition in this is a stent underexpanded, and MLA about 31% stent underexpanded this area. You can also see the stent malapposition, and you can see asymmetric, you can see the edge dissection and protrusion. These are the important problems post-stent implantation. Regarding the criteria to assess the dissection for optimal stent result, the large dissections are independent predictors of MACE. Presence of residual plaque burden, extensive lateral more than 60 degree and more than 2 mm longitudinal extension, and involvement of deeper layers of the medial or adventitia and localization distal to the stent increases the risk of adverse event. If your dissection is less than 2 mm and less than 60 degree, the chance of restenosis is less. Dissections are to be addressed. If it is significant dissection, you have to be very aggressive. If it is a mild dissection, and you have to be, should not be more aggressive. And OCT guided dissection, you can see the edge dissections, the reference segment disease you can see now. And this is a case where the left main stenting was done, but post stenting it doesn't appear to be, it appears to be very good, and you can see the good result. But however, you can see the proximal edge dissection. This dissection, though it was up to 6 mm, but it was not deeper, and it was not more than 20 degree, and it in the arc. So I left it like this in the left main, and the follow-up the patient was it was not needed to put another stent on this. And regarding the malapposition, lack of contact of strut with the vessel wall, it could be an acute or it could be a chronic. Long-term effect of not clearly understood in these situations. However, you can see the apposition is longer than 3 mm and more than 0.3 mm from the wall is a common practice to dilate with semi-compliant balloon at lower pressure. You can see this patient, there is a mismatch of the proximal and distal segment. I used 4 mm balloon, but in spite of that, the OCT shows there is a significant malapposition. Instead of using 4 mm, in spite of using 4 mm, then I post-dilated with the 4.5 mm, that gives a better result. Criteria for assess apposition for optimal stent result, the clinical relevance of acute malapposition is uncertain, though extensive malapposition after stent implantation should be avoided and corrected if anatomically feasible. Early strut coverage may be promoted by full apposition. Acute malapposition of less than 0.4 mm with the longitudinal extension of less than 1 mm should be left alone. Late acquired malapposition represents an established cause of late and very late stent thrombosis. And stent under expansion is a very important predictor of stent failure. MSA is either absolute or relative. Bigger the absolute stent area, better the outcome. MSA of 5.4 millimeter square in doctors are using IVAS. However, MSA of more than 90% of mean reference area, better outcome in the Illumin trial. So there are different way of looking into this. You can see in this under expansion of about 58% and 52% in the proximal and distal segment, if post dilatation it comes to 87% and almost 100%, and there is a very good result after that. So MSA is 6.17 and it is post dilatation, it comes to almost 100% results. This is another patient with the tissue prolapse, is another indicator of subsequent event, and this patient had a significant calcium throughout the RCA, and after rotablation, after ballooning, after lithotripsy, we got a very good result. There was no under expansion. However, this patient has come back after 6 months with a significant acute coronary thrombosis, with a significant stent thrombosis. You can see neoatherosclerosis probably, and with ACS, and this is post-dilated, and then we got an acutely good result, which is still in the follow-up. And criteria to assess optimal stent results, a relative stent expansion of more than 80%. That is, some studies is taken 90%, but 80% is most of the studies is the consent. It is a consensus, more than 80% MSA. An MSA of more than 5.5 by IVAS and more than 4.5 by OCT should be achieved in non-left main lesions. Clinical relevance of acute malapposition is uncertain. In spite of that, extensive malapposition after stent implantation should be avoided and corrected. Acute malapposition of less than 0.4 mm with a longitudinal extension of less than 1 mm need not be corrected. Late acquired malapposition represent an established cause of late and very late stent thrombosis. Tissue prolapse in ACS as compared with the stable CAD is adversely related to outcome. Large dissection detected by IVAS or OCT are independent predictor of MACE. Presence of residual plaque burden, extensive lateral extension, and longitudinal extension of more than 2 mm should be, and localization distal to stent increase the risk of adverse event. Thank you very much for your kind attention.